Going live. Okay.
Thanks.
Okay, so we are live. We can begin.
Well, hello doctors. Myself Dr. Rahul Mandlik, heading medical affairs at Shalina Healthcare, and I'm talking to you from Dubai. On behalf of entire Shalina Healthcare colleagues, I would like to welcome all participating doctors to this webinar. I would also like to extend our warm welcome to our speaker, Dr. Sanjeev Mehta. Well, before we start with webinar, I would like to quickly touch upon our corporate profile. Shalina Healthcare is one of the largest pharmaceutical companies in sub-Saharan Africa. So it has been our mission from last 35 years of making quality medicines and to ensure that they are available at affordable prices across Africa. And we achieve this by making our medicines at our own WHO approved facility, as well as by procuring some medicines from other WHO approved facilities. We consider ourselves as one of the important and integral parts of Africa's healthcare value chain. And that is why we strongly believe in continuously educating and updating our doctors so that you can take informed decisions while delivering best care to our patients. And this is one more attempt in that direction. Today, there are hundreds of doctors. They are attending this webinar from different countries across Africa. And today we have with us one of the senior renowned chest physician from India, Dr. Sanjeev Mehta. Dr. Mehta is going to shed some light upon some practical problems and clinical management of COVID-19 cases. And Dr. Mehta is currently associated with most reputed hospitals in India, that is Lilavati Hospital and Apollo Hospital based in Mumbai. Dr. Mehta has got wide experience of more than 2.5 decades practicing in chest medicine. And he is also a founder of Lung India Foundation. And Dr. Mehta is also founder state chairman of Indian Chest Society. So while taking this webinar, if you have any queries, please feel free to post them on right side panel on your screen, which will be taken up for discussion during Q&A session. So without taking much time now, I would like to hand over the session to our speaker, Dr. Mehta. Thank you.
Thank you very much. Can we start, Rahul and everybody?
Yes, sir. We
Yes,
can
sir.
begin.
Okay, great. Okay. First of all, thank you very much for the kind introduction, Dr. Rahul. I'd like to thank Dr. Rahul, his team, and Doc Mode for making this presentation possible. Friends, it's a pleasure to welcome all of you, and it is indeed an honor to speak to so many physicians from across different countries. It's a privilege and a pleasure to do the same. Now, we have been bombarded by this new disease, and I'm going to share a few thoughts about it. And I've labeled this as COVID-19, an update. So let's tell, most of you know a lot about COVID-19, I'm sure. I'm going to touch some of the basics, but I want to talk about what is new and what is important for us. So, what is a coronavirus? Now, COVID belongs to this family of coronaviruses, which cause a lot of illness in humans and in animals. Occasionally, the virus can transfer from the animal host to a human host. And when it does that, it has the potential of creating a lot of problems. For the most part, the stable human coronaviruses, which cause a normal common cold, are fine. All they do is cause a little bit of cold. The patient has a seasonal flu. Everything is okay. Once in a while, when they move over, especially when they move from the animal host to the human host, the first time, we don't have even any immune responses to that, and that gives rise to severe disease such as the severe respiratory distress syndrome, as was SARS, or the Middle Eastern respiratory syndrome, which was MERS. The MERS came from camels. The SARS probably came from civet cats. Um, so we really don't know. The new kid on the block is the COVID-19. Uh, it started in Wuhan, China. We really don't know what is the origin of this virus. Some believe it came from bats. Some believe it came from the cold, the wet markets. We don't really know. It has a very high similarity with the bat coronavirus, and that is a present assumption. But it also has a very significant similarity to the previous SARS virus. So we look into that in a bit. But at the moment, it's causing a huge problem in the world. So this is the snapshot of the WHO site this afternoon, about 1 hour ago. Nothing has ever looked like this. 4.3 million cases worldwide, 300,000 deaths in the world. Nearly every country is affected, 216, and it is creating havoc everywhere in the world. This is data from India about an hour ago. We have about 85,000 cases, 2,750 deaths. We are going through our lockdown. For the size of the country, I think we are doing very well, but the problem is there. It's there in India, as I'm sure it is either already there or can happen in wherever you are sitting. And that's a funny part of this guy. This virus has shown to be equally harmful in any temperature, in any weather, on any substrate. So we saw this in China, which is cold. We've seen this effect in India, which is warm, and Europe, and across all countries, all temperature zones, all weathers, height, low. This guy is a lethal killer. Is a threat to humanity. Let's get to know a little more about this horrible disease. So I'm not so sure. Can you see my arrow? I hope you can. So this is what the virus looks like. Rahul and you guys, can you see the arrow? Okay, I hope you can see the laser pointer.
Yeah,
So
we can see.
So this is what the virus looks like, and it gets its name corona from this spike protein. You can see the spike protein. You can see the spike protein, which is all around the virus, and it gives it this shape. In fact, if you look at the photomicrograph, you can probably see some of these spike proteins here too. But in the schematic, in the diagram cartoon, you can see these spike proteins, which give it the shape and the name and the distinctive feature. This is a single-stranded RNA virus, which has an envelope around it and has these hemagglutinins on the side. But it is this guy, the spike protein, that we are most interested in because, and this is what it looks like. So this is the shape of the spike protein, the stem. It has various parts to it. I'm going to discuss some of this in the future as we go along today because it has impact on its pathogenesis and potential treatment. So this is what it looks like. And it is instrumental in causing the damage to the human being. So you can see here that this is the virus. This virus has this spike protein. This spike protein then attaches to the human angiotensin converting enzyme 2 receptor. This receptor then activates internalization. So you understand that if there was no spike protein, the virus cannot enter the human cells. And that's why this spike protein has become extremely important, and you'll hear a lot more about it. One of the corollaries of this important finding is that many of the patients who are on angiotensin 1 and angiotensin 2 receptors and ARB blockers may have upregulation of the ACE inhibitors, the receptor. And maybe that is why, maybe, please remember, maybe that may explain some of the initial findings of higher morbidity and mortality in patients who are diabetic and hypertensive, and also on this these class of drugs. But now the guidelines say we don't need to stop these drugs because they do more benefit than harm. So we'll continue. But keep that in mind. It is this spike protein and its interaction with the angiotensin receptor, which is the cause of the virus getting into the human cell. So what does it do once it comes here? And now I'm going to show you this. And I think even if you are a family physician, some of this is going to be critically important for you. So what are the symptoms? The common symptoms, most common, are fever and cough. Nearly everybody will have fever and cough. Some of them will have sore throat. Some will have shortness of breath. We see an occasional patient coming with headache, body ache, nasal symptoms. But while this is from the CDC guidelines from USA, which say that few of them get it, but in my own experience, we are seeing a lot of patients who come to us with loss of taste, loss of smell, nausea, vomiting, and GI symptoms. So clearly this disease affects not only the respiratory symptom, but goes into the entire body, causing headache, muscle pain, so neurological symptom. In fact, we have a couple of people who become unconscious. So it's affecting the neurological system, the muscular system, the GI symptom, the loss of taste, loss of smell. And beautifully, we see that when they start to get the taste and smell, that's also a sign of recovery. Which patient should you rush immediately to the hospital? Anybody who tells you that he or she has difficulty in breathing. Many of them will tell us they have pressure on the chest. Why would you like to take them to the hospital? Because of two things. One, of course, that this may be cardiac. Remember, COVID can hit the heart bad. You have a lot of young people coming, especially seen in the US, but even we are seeing them, who come to the emergency room dead on arrival. They had a heart attack. So this could be a symptom of heart attack, but also there is this condition called happy hypoxia. There's nothing happy about it, except the patient says, I'm fine. You do the saturation, he's got 80%. So I encourage you all to keep a pulse oximeter with you and take the pulse oximeter of every patient who comes to you now. You will be surprised how many of them have low oxygen. Of course, if he has blue lips and confusion or is obtunded, you're going to take him straight to the hospital. Now, this is a very important initial study that was seen in China. That's where it all started, where the initial studies came from, which tells you that the maximum effect is seen in the elderly and those who have comorbid conditions. This chart is very interesting because you can see that if the patient is young, has no comorbidities, the chance of getting into hospital is 2%, chance of 6%, chance of getting into ICU is only 2%. On the other hand, if the patient is elderly, has underlying conditions, comorbidity, then the chance of hospitalization is 45%. That means half the elderly are going to get into the hospital if they get the virus that is above 65, and at least one fifth of the total patients are going to end up in ICU. That's about 20%. So clearly, if you are above the age of 65 and you have comorbidities, then your chance of having a bad problem is quite high. The comorbidities could be any of these: asthma, COPD, emphysema, smoking, liver disease, patients who've received chemo. We have a fair number of patients now who have been on chemo, came for a routine evaluation, and they were COVID positive. Same is with dialysis and patients who've been on chronic steroids. But here I'd like to tell you that if your patient is asthmatic, do not stop the steroids. If he's taking steroids for any other condition, do not stop them, continue them as they are. But be what it may, this is the number. Young, 6% hospital, 2% death. Old, 44% hospital, death can be as high as 20%. So this is the statistics that is there right now. And one of the reasons is, and this is a slide that shows, there are far more ACE receptors on smokers. So if you're a smoker, this is the time to stop. It is never a good time to start, but if you have been smoking, then it is increasing the ACE receptors. Stop. If you're a COPD patient, the ACE receptors are more clearly becoming a magnet for the virus to get in. A recent study showed cancer patients doing extremely badly. So once the virus gets in, then what is going to happen? Now, I don't want you to panic. About 80% will have no or mild symptoms. Data from India, Maharashtra, that's where I am, Bombay, today showed that 70% of our patients are asymptomatic, which is good. It is also not good because they're spreading the disease, but the point is they're not a risk to their own life. 20% will become seriously ill with breathlessness. The older patients have a bigger problem. But I want you to remember this. Don't think that if you are young, you can be safe. We have seen youngsters die of COVID disease. They can get heart problems, they can get any problems. So no age is safe from COVID. And the other thing is, do not be fooled. I already told you about the concept of happy hypoxia. Many people will come too late to the hospital and that's when they die. So you need to be aware of that. The other thing you need to be aware of is that a patient can suddenly collapse. So just 5 days ago, I had a 68-year-old gentleman come to me. He looked okay. And I said, you know what? He obviously asked you, what do you think? And I said, I think you're going to be all right. You got a little cough. Next day, he was feeling better actually. So this is now 24 hours after hospitalization. 48 hours after hospitalization, he was put on a ventilator because his breathing stopped. And 50 hours after hospitalization, he was on inotropes. So the progression can be terrible. We had a 68-year-old doctor admitted about 2 days ago, got admitted in the afternoon at 1 p.m. By 12 at midnight, he had to be put on a ventilator. Unfortunately, we had no beds. He had to be put on a ventilator in the ward. It's a disaster. So please remember, this is a terrible disease. It's a terrible disease. And you should ramp up your medical care facilities. Do not be fooled. Anybody can get it and anybody can get it bad. Take it from me. It's not something that you want anybody to get. I'm a pulmonologist, so I'm going to talk to you about what it does in the lung. Once the virus gets in, it enters the lung and then it goes through this. This is a very important slide. I'm going to have a sip of coffee and I'm going to talk about this slide. So I want you all to focus on this. This has important both diagnostic and therapeutic value. So normally in the first week or so, and while this is not, there's no fixed timeline, this can be 2 days, it can be 7 days, the virus gets in. And when it gets in, it will cause symptoms such as fever, diarrhea, body ache, headache. Now remember, this is the virus that is causing the damage. If you did a blood test, you will see low WBC count, increased prothrombin time, D dimers and LDH. The low WBC, increase in D dimers tells you that this guy is heading for trouble. As the phase 2 gets in, the body starts forming antibodies or starts to fight the virus and start a host immune response. So over the next few days, the virus starts to die, but our immune response increases significantly. And I'll tell you that. So the virus does not necessarily kill. It causes ARDS and problems in the chest, in the liver, in the lungs, everywhere. Hallmark is low PCT. But it is the autoimmune, our own hyperinflammatory response that causes ARDS, shock, cardiac failure, and death. One of the hallmarks of this acute inflammatory response is a high C reactive protein, high IL-6, high troponin, and anti-proBNP, showing extensive damage, but the inflammation is CRP and IL-6. I'm telling you this, I know that many of you are general practitioners, but you need to be aware that these are the tests that we do now. Why somebody is going to get a bad response, some don't, is a genetic predisposition in the macrophages. In patients who have a genetic predisposition, when they get high levels of IL-6, interleukin beta, they have a deficient response in terms of the immunology. You get a massive cytokine storm, and it is this cytokine storm that kills. And much of the treatment now is focused towards managing this cytokine storm. If you pick it up early, then you can treat the patient early. And we are doing that now. Within the lung, once the SARS-CoV virus gets in, it binds to the alveolar macrophages. It then causes damage to the lining of the lung, the neutrophils, and this causes a hyaline membrane to form. So let's look at it this way. And this is a very busy slide. I have to apologize. I could not break it up. I'll walk you through the slide. I'll explain everything to you. So this is a normal cell. The white cells, the blood RBCs are here. This is air in the alveolus, and it does its job of gas exchange. When this virus gets in, it then causes the virus to bind to our pneumocytes. And when it binds to the pneumocyte, sets up an inflammatory response, it then causes leaking of fluid in the airway. You can imagine if there is fluid in the airway and that looks like this, there is no gas exchange happening, the patient will become hypoxic. As this becomes a more proteinaceous fluid, the lungs become completely choked and the patient is going to die. So this is the important time when the virus gets in and this immune response gets set up. This is the time when there is vasodilatation, cytokines, and surfactant release, giving rise to this protein-rich fluid with hyaline membrane. You can see the hyaline membrane, and this is causing your choking. So basically, the patient is choking on his own secretions. He's dying because every one of his alveolus is blocked. And so this is what you should do. If you're mild, first stage, stay home, and of course, then get into hospital and ICU. So if your patient comes, and I know a lot of people are doing CT scans, not required, but I'll talk to you. But you can see when the first amount of air gets in the lung, it causes this little whiteness in the lung on CT scan. This is called a ground glass opacity. As the inflammation becomes more intense, this is day 5, and you can see that the whiteness has become more dense. The interalveolar septae are prominent, and this is called a crazy paving. Crazy paving means that the alveoli are inflamed and the interlining septum is also inflamed. Here it's only an alveolitis. In the next few days, you can see the rapidity of spread. This becomes a massive GGO, ground glass opacity. You can see the ground glass opacity all over the lung, and now this patient has disease in the entire lung and with consolidation. You can imagine with this situation over here, how will there be any gas exchange? This patient will need ventilatory support and very high levels of PEEP. This is another picture of a patient who had massive SARS COVID viral infection going on to ARDS. And you can see that this is extensive disease affecting every part of the lung. Now, I don't know how many of you are interested in looking at the tissue, But you can see that this is the inflamed tissue. And in the next slide, I'll show you a little more detail. So this is where you should have air. What you have is fluid. This should be thin, only one RBC, but you can see how thick is the interlobular cell. Look at the interstitium. This interstitium is thick. It should have air. But now with this thick interstitium, air cannot exchange. You start to get more and more. Now this is like forming, fibroblastic fossa, mucus plugs going on to the picture which we know as COP, and then this destruction of the cells, abundant macrophages, and you can see that instead of air in the lung, there's inflammation in the lung. This patient cannot breathe and obviously is going to choke and will need ventilatory support or may die. So which patient, when are you going to do an X-ray? This is, and now you're going to see all my image slides are very recently referenced because everything is happening very aggressively. We don't know this disease. It was not there 4 months ago or 6 months ago. And now societies are coming with guidelines. If your patient is healthy at home, having nothing, which is going to be 70 to 80% of your patients, you really don't need to do even an X-ray. There's no need to even ask for a CT scan unless you think this patient is going to progress. So imaging is indicated for the moderate to severe patients, and why that's important, you don't want to overwhelm the system, right? And you only do it for those patients who are really sick and who are going to get worse. That's when you do X-rays. We do serial X-rays. We would like to do a CT scan once for diagnosis and look at the ground glass opacity. The other problem is we can't do bronchoscopies in these patients because of the risk of aerosolization. So you got to go by X-ray and CT scan. And if you don't have a CT scan, keep doing chest X-rays and follow the progress of the disease. You should correlate with blood gases as far as possible. So this guy is a bad guy. It affects the lung mostly, but affects all other organs. And you can see here, it affects the brain. I told you we had unconscious patients, the heart, patients get heart attack, blood vessels, kidney failure, and I'm going to tell you a little bit more as we go. So this is the damage to the lung. I already told you, this massive inflammation and mucus secretion. New studies are showing that it is not only affecting the alveoli, but also affecting the blood vessels within the lining of the lung. So, and I'm going to tell you that in the next 1 or 2 slides, that for some reason, which I'm not yet aware, I don't think we have the answer, there's a lot of blood clotting that happens. That's why the D dimer is high when the patient comes to you. These microclots block the circulation wherever they are. So in the lungs, they give rise to pulmonary hypertension and less blood supply, again causing hypoxia. In the heart, these clots, we've seen that, can form and people can come with sudden cardiac arrest, sudden arrhythmias, and myocardial infarction. So a fair amount of our patients have high troponin levels, and of course, most of them will also have high levels of NT-proBNP, showing two things: less oxygen to the heart and also big strain on the heart. The neurological involvement is there. There are strokes, confusion. We really don't know what is happening, whether this is because of the virus or the immune response. I think it's the virus, the nose, the liver, the kidneys. One of the big problems in kidneys is that if you got to dialyze these patients, because of the clotting, the dialyzing catheters get blocked. So first of all, the kidney gets damaged because of the clots and the sepsis, but also the dialyzing becomes a challenge. And even with high doses of anticoagulants, dialysis tubes can get blocked. So dialyzing them is a challenge. And then, of course, the intestines are rich in ACE inhibitors. So many of these patients have diarrhea, dysentery, and GI symptoms. In my experience, most of them get well, but not all. This is something which I talked to you about, the blood clots. you can see that it clots all over the body. We don't know why this happens. We need to give very high levels of blood thinners, but this is what worries me. I'm sorry about the busy slide. It just came 2 days ago. What it shows is 10 boys, 7 boys, 3 girls in Italy, and they had blocking in all the arteries. This is called Kawasaki's disease, which is an inflammation of the arteries, the arteritis. And as this arteritis happens, patients cannot breathe. Patients get clots, and many of them die. A recent report came from New York, similar thing, and we thought children are safe. No, nobody's safe. The children are not safe, and children from the age of 4 to 5 to 15 have died, 3 out of 15 in USA from Kawasaki disease. Again, we don't know whether this is part of the virus itself, or is it because of the hyperimmune response, autoinflammation is set up, or it's immune body complex mediated. We don't know why it happens, but we do know that if you have a kid, don't think everything is okay. That child can also be affected very severely. All right, so that's what it does to various organs. I could go on and on, but let's get on to management. So if I had to talk about treatment of COVID disease, I could leave the talk here and say, that's it. There is no treatment. What we have is management, because no specific treatments are available. What we do is supportive care, but let me go through whatever we have. So in the next 4 or 5 slides, I'm going to talk about the latest guidelines from the National Institutes of Health in USA. Now remember, this is April 22nd and we are in May. A lot of things have changed. Every day new things are happening in this disease. I'll try to walk you through some of them. So one of the things that hit the headlines, thanks to a very important president, is chloroquine or hydrochloroquine. The guidelines from the National Institutes of Health, and I know this is supported by the American Thoracic Society, say there's not enough evidence for or against the use of hydroxychloroquine. So there are some reports. There are 1 or 2 studies. One French study said that it reduces viral load, but that was only part. In the treatment arm, I think 4 patients died. 1 went to ICU, 1 was lost to follow-up. They were not taken for analysis. In the placebo arm, nobody got worse, but their viral levels are high. So I don't know how to interpret this. I don't have an answer yet. In another study that came out a few days ago, showed no benefit for hydroxychloroquine. So should you take it? Should you not? Should you take it for prophylaxis? Well, the ATS says no need to give it for prophylaxis, no need to give it to asymptomatic patients, but give it for the severe patients. Should you take it? Should you not? That's entirely up to you and your guidelines. Indian Council of Medical Research, the Indian guidelines say everybody should take it. So we are giving it to our doctors and patients alike for prophylaxis and for treatment. That's our guideline. A lot is made out for remdesivir. Now, you're in Africa, so you probably know a little more about remdesivir than I do. It was first brought out as a broad spectrum antiviral drug for use against Ebola and SARS and MERS. It has a checkered history, but initially they could not get any response. But a very recent report, I think, came out about 15 days ago or a week ago, showing that there is a 31% improvement in response rate in terms of early discharge or improvement in clinical condition. So now remdesivir has got the FDA approval on short-term basis for use. So remdesivir is been given on compassionate grounds in USA. A lot of other countries are looking at it. I don't know all of them. I don't think it's available in my country, so I don't use it, but this may be something for the future. What about the combination of hydroxychloroquine and azithromycin? Not recommended other than in a research setting. We have used it, but we use ECG or EKG twice a day, because the combination has shown, and we have seen it, to increase the QT interval, which may cause sudden deaths, arrhythmias and sudden deaths. So be very careful. This combination, lopinavir, rotenavir, has not found favor because research didn't help it. But now triple antiviral therapies are being used by some people. Again, this research is very small, and you have to take your own decision, and your hospital can make its own protocols. Now, we all know that the SARS virus and the SARS-CoV virus both have this spike protein. All of these bind to ACE receptors, and they both have this systemic response. The question is, if we can block it, will we be helped? And clearly, there is this concept of convalescent plasma. That means people who are recovering from this virus, they would have recovered by making these antibodies, and they have used it. There is some good success for SARS in using convalescent plasma. The success for COVID is not very good. So the guidelines is that we should only use it in a research setting. And I know that in Mumbai, that's a city where I am living, there are clinical trials going on. 3 hospitals are under presently trying it. When it was not in research, we have used it very small, 1-2 patients, too early to say anything. I hope the research will help us to know how we can use this convalescent plasma or hyperimmune immunoglobulin for COVID. Now, another drug that is being used significantly is tocilizumab. Again, NIH says that not enough data. We used it initially. My answer is that I don't know what to do with this. I think we were using it too late. So the latest in our setup is we use it early. As soon as a patient becomes unwell or is moderately ill, we send IL-6 levels. If they are high, we use tocilizumab. Is it working? We don't know. I think better trials will tell us. At the moment, there's inadequate data. So if you think it is working, you can try it. We don't use IL-1 inhibitors such as anakinra, but you have to see your setting. There is definitely no recommendation to use interferon or any other such immunomodulators. And so also the Janus kinase inhibitors. What about steroids? Steroids have been with us for a long time. Should we use them? Should we not? And the answer is, we don't know. At least in the early phase of the virus, we are not using it. In the later stages, if there's a massive inflammation, we have tried a little bit. Again, very little data. But if your patient is in septic shock, you can use a low dose as therapeutic replacement for septic shock. So that's where you can, not for the disease, but for the shock. But if your patient is taking the NSAIDs or steroids, don't stop them, continue at the same dose. So this is the guidelines. The guidelines tell you not to start angiotensin receptor converting enzymes or ARBs, but if they are already on the drug, don't stop them. Statins, the same, don't stop them, don't add them if they are not there. And ECMO, if your patient is seriously ill, you may use ECMO if you have the resources, the cost, everything. It'll give you a little bridge. We don't know what the success is, but if he has the ability to have it, then you can. We are using a fair amount of prone ventilation. I don't think there is something specific, but at least it helps to tide over the crisis till ECMO or something else works. So going towards the end, what does the future hold? Well, there are a fair number of vaccines and drugs under development. About a week ago, we got this study that showed that in China, out of the 285 patients who were tested, nearly everybody developed antibodies, which are antiviral IgG and IgM. And they came roughly after the 6th day of the seroconversion, and the patient got well. So the question is, are these protective? Are these protective antibodies? How do we identify them? So research is going on. The logic is that this is the ACE in a receptor. This is the spike protein. If you can block it by giving a protective antibody, then you may be able to prevent the virus from getting into the human cell. And if that happens, that's great. So most of the vaccines are targeted towards hitting this guy, the spike protein. So I'll show you a little bit more about the spike protein. So this is the spike protein, and I won't go into details, but part of this is unique to the COVID virus. Some of it is overlapping with the SARS virus. What is being done is trying to target that unique area, maybe even the stem, so that we can get an antibody that is going to be effective. The challenge, of course, is that this virus is undergoing mutations, and I really don't know what is the present mutant strain, but every day we get new data or new information of the mutation. So if there is not too much mutation, we may get the viruses. So we may get the vaccine. So a lot of vaccines are in development. You see this 115 projects, 5 on clinical stage. But I want to warn you, don't be hopeful or don't be very over hopeful. Till today, we don't have a vaccine against HIV. We don't know if we'll get it. We don't know what will happen. We just hope and pray. So what about drugs? So before I go further, I can share a little bit about the old drugs which are being used. And you see, I'll just walk you through this. So this is the virus, joins the ACE inhibitors, gets internalized. It then gets uncoated. This forms a negative strand, which then directly becomes a, joins in the human body. Positive strand gives the order to the human body. It takes over the human body. It's like hijacking us, and then tells them, the human body then makes the components as directed by the RNA strand. This is the life of the virus, and that starts getting packaged through the various systems and goes out. So because of this, various drugs are under development. Can we block the internalization? Maybe we can block it here. And that is nefamostat and camostat. They can block it. Or that is where chloroquine may be working, or hydroxychloroquine, preventing the internalization. Or endosomal acidification. If it gets in, then before it starts the replication, then remdesivir, flavipiravir, or maybe even cycloserine A. So if it starts multiplying, then these antiviral drugs may work. So that is a logic. We know that there are drugs that are there. We know that they may work, but so far we don't have good clinical trials, and maybe they need to work in combination. What about the immunology? And this is where we have the antigen presenting cells, the virus gets out, and that is where things like tocilizumab may be working. So this is just one of the drugs, nefamostat, which may be blocking the binding here. It may block the binding of the ACE receptor with the spike protein, inhibits it through activation of other proteins, which are activating the cleavage. So there is a lot of hope here. This is really my last future slide that is really cutting edge. And I find this exciting, that the viral RNA gets in, this gets sensed, and this small viral RNA proteins then go in and set up the inflammatory cytokines. So we're looking at these short chain and long branched double-stranded and single-stranded RNAs, which will go. So if literally we are getting at the molecular level to target the disease. And I think this is where the future lies, not in the big, broad approach, but beautifully knocking out the sequencing of the slide of the virus formation and development. So there are a lot of these drugs that are under development, and let's hope for the best. I'm going to quickly run to, I've got another 2 minutes. I'm going to run through these FAQs, but the FAQs can be for an hour. I'm happy to take questions. How did these viruses come? The SARS may have come from bat to the camel to MERS, and then from civet cat, this is SARS. So who knows? Maybe the new one came from pangolin. How long does a virus stay on surfaces? So there's a lot of studies. There is a New England Journal article that says it can stay on plastic for 5 days, paper 4 days, glass 4 days, wood 4 days. But most of the times we believe that after 24 to 48 hours, it's gone. So don't go by this. But what this slide tells you is there is so much importance of hand hygiene. If you touch anywhere, before you touch yourself, please, please, please do hand hygiene. Please, please, please wear a mask. So there is no question that this virus, which is mainly by droplet, very little by aerosol, those droplets can go and you can get these fomites, which can spread it. You need to be careful. How can you prevent it from going to you and others? Wash your hands, keep very important distance. 1 to 2 meters. And it's really funny, in our OPD now, we talk to patients who are 2 meters away. In fact, more than that, it's great to do teleconsultation. I think that's the future. It feels so much better. You are safe from the patient. Keep your eyes covered. So all of us will wear eye protection. We'll all have triple layer surgical mask. But in the COVID ward, in the hospital who's sick, then N95 surgical, N95 respirator. Don't let patients cough in your presence. They should be very well covered, you and the patient. We don't allow relatives in the room. And, keep cleaning all surfaces regularly. Should we stop ACE inhibitors, ARB? No, but don't start them if you don't already have them. So this is my last slide. Are we back to the future? This is a slide from 1918 influenza pandemic. And you see all these ladies wearing fashionable homemade masks, or maybe those are factory made. But I think this is the future. We are all going to be moving around with masks for the future, saving yourself and everybody around you. I think this is extremely important. Social distancing and masks, telemedicine, and all such things. With that, I'd like to thank you for your kind attention. I'd like to thank Rahul, Dr. Rahul, for arranging this. Thanks, Rahul, Doc Mode for arranging this, and all of you for your patient hearing. I hope this has been of some help to you. If there are any questions, I'm happy to help you with whatever limited information I have, because this is a crazy disease. It's showing new patterns every day. It is manifesting every day. Whatever I say today could be wrong tomorrow. Thank you
so much, sir. Yeah, thanks. Now we are at Q&A session. Actually, you have covered most of the questions. Though we have got many questions and still we are getting the questions, but you have covered most of them. I would like to touch upon few areas. The questions asked by our audience. Like, doctor, like in many countries, it is challenging, screening of patient, and enough testing kits or testing facilities are not available. So considering primary care healthcare setup, and where not much testing kits are available or not at all, in that case, are there any tips from your side how to differentiate between COVID-19 patient and regular influenza flu patient, quite in initial stage?
I think it's a very important question. It's a very important question. We don't have kits for everybody in the world. There are 7 billion people. We don't have that many kits, and many can be tested again and again and again. So your question is very important. My answer to that is, there is no way to know whether this patient is got COVID disease or any other disease. Would I like to know? Sure, I would like to know, but I cannot make out on symptoms alone. My only thoughts would be compared to other viral diseases. So if it's a short duration, you know it's virus. If it is 6 months fever, it is going to be TB. So first, short duration. Which is the virus that is going on right now? It is going to be COVID. But if they are also associated with nasal symptoms, loss of taste. I've never seen loss of taste, loss of smell with a normal flu. So fever, body ache, cough is okay. So two things which I think are important, loss of taste and happy hypoxia. If your patient is sitting in front of you and not feeling bad, but you do a pulse oximeter and his saturation is low, then I think this is COVID. But that being said, it is universal precautions. Treat everybody during the epidemic as it is going to be pandemic as a patient of COVID and treat him with whatever you would normally. If you can't test him, you can't test him, treat him. Well, there's no treatment. So you're going to give management. Mainly, you're going to isolate that patient and give him antibiotics and bronchodilators for the respiratory tract. There's really no. Of course, we are using wherever we are desperate. So we do use things like hydroxychloroquine and anything that your country, if your country's medical council will tell you what to use, go with that. Again, we also understand we are testing less because we just can't have that many kids. So every day we get new guidelines, and sometimes you don't need to really struggle with every asymptomatic patient. But then if you can test, then you should test everybody.
Okay, and Doctor, like as far as patient's journey is concerned and connecting patient journey to clinical manifestations, so how would you like to guide how the progression of symptoms that takes place from mild, moderate to severe, so that will guide doctors in the better management.
Thanks. So I did mention this and I dwelled on this a little bit in detail. Mostly, if you remember that slide I showed you with the two triangle, which were merging like this. So the first symptoms 1 week are viral. So fever, body ache and all. Then acute severe breathlessness and ARDS, that is our cytokine storm. So usually the first 7 days are mild. After 7 days, they get moderate symptoms. The lucky guys are going to stop at moderate, but the severe can become suddenly severe. Please be aware of that. So if your patient is unwell, take him straight into hospital and attend to them. He can crash. I gave you two examples of patients who just came in and crashed within 48 hours. We had many patients who've been at home, reached hospital dead on arrival. So for that small number, that 2 to 5%, if they're going to get a bad attack, they're going to get a bad attack.
Okay. Dr. Edwin is there from Ghana who would like to know which can be the management options for severely ill patient with COVID-19, since there is no clear-cut treatment options available.
So in most patients who are severely ill, the management is supportive. So in our setup, as if they're severely ill, we will try to manage them with high. So there are everything. Let's go over it. So patient is severely ill, you're going to have to give him oxygen. The next step is going to be high flow nasal oxygen. We try to avoid using a NIV because of the risk that they're going to be aerosolized. But we do use NIV with proper filters on both sides. Okay. Now, if they need to be, then we go ahead and intubate them. But tracheostomy is something which is very difficult to do because of risk of aerosolization. So that's on the respiratory tract. Once they get on a ventilator, they're going to require high PEEPs and even prone ventilation. We do use in such patients solumedrol or methylprednisolone because we want to take care of the storm, because by now they're in the cytokine storm. One of the things which we are doing now is considering and using a fair amount of tocilizumab, because IL-6 is one of the mediators of inflammation. And I don't know, but some people find it very useful. I think it is useful. It's difficult to say, but I think it's useful.
Right.
And then,
And
of course, the supportive care. The heart is involved, the brain is involved. We take care of everything, nutrition, everything. And again, the other important thing is high dose of anticoagulants. So a lot of higher doses of anticoagulants, LMWH.
okay. Uh, yeah, you have mentioned about vaccine quite in detail, but there are few questions, particularly from, I can see questions coming from Ghana and doctors from Angola, Dr. Coelho. These doctors mainly would like to know about vaccine development and status in India.
So there is the doctor and there is a politicians. So I think everybody is very hopeful that there'll be a vaccine tomorrow. My own answer is that I don't know. The more scientific doctors like Dr. Fauci will tell you it's an 18 months period. Now, the reason why it's 18 months is the following. We know the target. That has been very quick. In 2 to 3 months, we know what the target is. But we don't know how it is evolving. So the question is, like in HIV, is your target stable or is it going to change? If it is going to change, you may have a vaccine for one kind or one epitope, but it may not work. So we first have to get the vaccine. And I know they have tried already human trials. Then you have to see how long what is a dose, whether that dose is protective. So I may have antibodies, but these antibodies may not be protective. So it is okay to have anti-COVID antibodies, but they are like a drunk watchman who's sleeping on duty doing nothing. You could put 20 drunkards to protect your building, but if they're all drunk and not doing anything, then they're not. So if you have ineffective antibodies, so I think we're going to have to go through the process. It's going to take time. I'm even saying we don't know if we'll ever have one, but I hope we'll get it. I'm praying for it. I want to take it myself. I don't know when it will be available. And in India, I know there are started human trials, I think, on I think in Pune they've started.
Okay. Well, Dr. Maloba from Kenya would like to know, his question is more towards cardiology, how to manage heart failure in COVID-19 patients.
No, I lost you. I couldn't hear that question. Sorry. How?
Dr. Maloba would like to know, he's from Kenya, how to manage heart failure in patients with COVID-19.
With a very big heart. So the answer is, yeah, you treat it the same way. We are doing exactly the same thing, but a couple of things. One, we are testing them a lot, okay? Because now we're picking them up much earlier. We're doing practically TROP-Is and NT-proBNPs on, as soon as a patient enters the ICU or needs to be in ICU, we're testing them. Doing a lot of EKGs, so we're testing a lot. We're treating them with much higher doses of anticoagulants. Many have come with acute myocardial infarctions. The problem is we can't do primary angioplasties because of the fear of spreading the disease. And it's a logistic nightmare. So a lot of my colleagues, I'm a pulmonologist, a lot of them are doing primary thrombolysis and then taking them for secondary angioplasty when they are probably much easier to manage. So I think when they're too intensely ill, then thrombolize them and hope to work with them. But otherwise, the management is the same. We give them antiplatelets, we give them blood thinners. But most important is expect it, look for it, treat it early, lot of anticoagulation.
Well, we have Dr. Vetu from Zambia, and he has quite compelling question. Doctor is practicing in a setup where he does not have much access to medical equipment such as ventilators. And doctor would like to know what happens if he receives patient in respiratory distress. How do doctor will continue ventilation with these limited resources?
So yeah, this is a difficult situation, and I hope and pray that you get the ventilators. I also hope and pray you don't get that bad patient. So first point is that only about 2 to 3% of your patients are going to require it. So I hope you're not going to get bombarded by it. But if you do, then you start with oxygen, give high flow oxygen. If you can, then try to use the rebreathing oxygen mask that can give you FiO2s as high as 60%, 70%, even though they say 100%, but you can get that. What you can't get is PEEP, but at least you can go up until there. If you have non-invasive ventilation, if the patient is getting unwell, try it. From the medical side, steroids treat the pneumonias, treat the infections. If you have, if you don't have ventilators, and I assume that you also will not have access to either convalescent plasma or tocilizumab. So if you don't have it, that's okay. But antibiotic, steroids, supportive care, oxygen, high flow oxygen, rebreathing mask.
Right. And there are a couple of questions
I
I
hope
can.
that helps. Yeah.
Yeah. Thank you, doctor. I can see a couple of questions on, like, particularly from Dr. David, who is from Nigeria. They would like to know about COVID-19 cases or management of COVID-19 in during pregnancy.
So sorry, I lost your last question again, little bit. During pregnancy.
Exactly.
So the thing is, um, we're not myself, but a couple of my gynae colleagues have been delivering a lot of COVID positive patients. So far, we have not seen any significant effect on either the mother or the baby, which is related to pregnancy. So this pregnant child, so first of all, they're younger, so that is lucky for them. Pregnancy doesn't seem to make their COVID worse, so that's okay. You have to deliver the baby and take all the precautions. If you delivered it in a particular delivery room, then you would sterilize that. But you need to wear all the protective equipment that you have. I don't know what you have. But remember that if you are having protective equipment, then your anesthetists have to be very careful. Oh, this is beyond my ability to help you in terms of anesthesia of COVID patient. That is, you need an expert in anesthesia who will tell you how to take the precautions. They wear masks, they have hoods, they have tents, all that. So that is as far as the infection part is concerned. As far as the medical part is concerned, you have nothing to worry. They do very well as like any other patient. They are delivered. That's okay.
Yeah. Well, I would like to take now last question, doctor. Dr. Gabriel is there from Ghana, and many doctors would like to know about the role of herbal, or I mean, we call Ayurveda in India, because doctors, our audience, they are from Africa, and we share common tradition and cultures, right? India and Africa, and we trust, on herbal treatments since ages now. So what is the role of doctor
Yeah.
herbal treatment?
So I'm a simple doctor. I have no idea about the science behind herbal treatment. Yes, I think if you have it, use it, but there's no science yet established. And I know that government of India is doing a study with Ayurvedic medication now. They just started a few days ago, I think 2 days ago. They started enrolling. I don't know the scientific vigor of the study, but do it. One of the things that we often talk amongst ourselves is that, if you look at it generally, there is more effect of the virus on in the higher latitudes, more death rate. The question is it temperature or is it our diet? So maybe something in our natural environment, the diet, maybe in India we eat a lot of turmeric, which is herbal basically.
Yes.
Is that helping us? We don't know. So if you have an herbal medicine and you want to take it, but remember, you don't know what the effect of that herbal medicine is on the virus. Do you think it is helping you? It may be actually helping the virus.
Well, thank you so much, Doctor. We have many questions, and for our audience, we'll take up these questions, we'll address them separately. And at the outset, I would like to extend a big thank to Dr. Mehta for these wonderful and much needed clinical insights on COVID-19. And Shalina Healthcare shall be continuously delivering such type of sessions, and we shall be conducting this type of events in coming times. I would also like to extend our thanks to all the doctors and audience who has taken time from their busy schedule to attend this webinar. And we at Shalina Healthcare, we salute all doctors for standing strong in this situation, right? And fight. You are driving. You are there in the lead seat, right? In war against this COVID-19. So stay safe, doctor. Take care of yourself while taking care of your patients. Thank you so much.
Thank you.
Shall we end the meeting? Yeah, thank you.
Hello.
Hi guys.
So we're done with the lecture, right?
Hello.
We are done with the lecture, sir.
हाँ? बंद कर दूं?
Yes, sir.
Bye.